Dr. Kosmas?
Okay, do you hear me now?
Very well.
Okay, let's start. We're going to present you a very interesting live case from our Cath Lab. And here is our team. It's about a female, 77-year-old female. Excuse me, one moment. Now you can see me, the presentation. Yeah. Arterial hypertension, dyslipid damage.
Yes.
Pulmonary hypertension, and here is the screening coron, absence of severe coronary artery disease, and very elevated aortic gradient, as you can see here in the screening echo. Here you can see the measurements. I skip that. Extremely calcified aortic valve and preserved ejection fraction. Here, from the screening coron, absence of coronary artery disease, as already spoken. And here is the CT angiography, the main measurements. You can see here that this patient fits the anatomical profile for SMART clinical trial, area below 430 square millimeters, and very not promising, I suppose not promising femoral access and high tortuosity. You can see later the images. This is about the SMART clinical trial. I skip that. And here you can see the CT angiography, the heights, the sinus height, the annulus. This is the measurements from the femoral arteries, both femoral arteries. Not favorable anatomy for transfemoral approach. Here you can see the tortuosity of the abdominal and the ascending aorta. And here you can see the right and left subclavian approach. I skip that. Here you can see the femoral axis from and here you can see the high calcified both aorta. And here is the subclavian right subclavian artery. Here are our measurements about the annulus perimeter. You can see here that's about 61 millimeters. So our choice is here is 23 millimeters. And the heart valve team of our hospital decided TAVI from right subclavian artery. Here is our cases from left subclavian artery, about 4.6% other than transfemoral access, and a short video about the graft in the right subclavian artery that Dr. Doulas just implanted a few moments ago. So we can proceed to Dr. Voudris now to finish the very, very interesting case.
All right, excellent, excellent. Yes, indeed, it's a very small valve. It would be either a 20 Sapien or a 23 Evolute fits there. But, you know, clearly it's a very small valve, fits by the SMART trial. We're going to have a talk about that later. As soon as we see, yeah, now we see the Cath Labs. Let's go again.
The most important thing in this lady is the very severe kyphosis, 90 degrees. You can see the electrode on right ventricle. How is it? And of course, the severe calcifications, the tortuosity, and the severe aortic stenosis. So the first, please, Martina. Okay, that's we try to go. Next, please. We are inside the left ventricle with a Landerquist guide wire. Next, please. Next, please. No, the first, the previous one. Okay, this is the pre-dilatation. Go. Next, please stay there.
So
You can see the pre-dilatation with 18 millimeter balloon.
18. Mm-hmm.
Next, please. Removal. I'm sure. Go, please. Continue. The second line, the 5. Okay, stay there. Go. 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 Go.
Okay, next. Yeah. Πολύ ωραία. Βλέπουμε πάλι τη διάταση εδώ. Where the
Okay.
predilation with the dilation with the 18 millimeter balloon looks quite big,
Yes.
actually. Again, the measurements of the annulus were 19 by 20. So an
Yes,
18, although it's a
exactly.
small size, it's pretty fitting for this situation.
Exactly. Next, please. Next, please. Next, please. And that's the valve. Now, so we are ready to advance the valve for the implantation. That's okay? Do you hear me?
Ναι, βεβαίως, έτοιμοι, βεβαίως. The valve is diving down from the right subclavian.
This is a 23 millimeter FX Evolute Medtronic valve based on the results of the SMART trial. I think this is the ideal valve for this lady.
Well, it came right in. That's the advantage of the right or the innominate access through right subclavian. In this case, it could be the similar through right carotid, for example. But it dives straight in. Very easy delivery into the ventricle.
Have a look. May have an angio, Martina. Okay.
Good. So this is a cusp overlap view you selected?
This is a cusp overlap, Georgiou.
Yeah.
Okay.
Well, to get the full benefit of the evolute valve, in this case, self-expanding valve, you have to try to implant as high as possible, because that's when the annulus becomes bigger for this valve. The diameter becomes bigger for this valve.
Please.
Biggest. Yeah, our pigtail got a little trapped behind the valve. Happens all the time. So in order to fix it, probably if it doesn't go easy, you've got to put a wire in there, but it happens all the time. But in this case, it works very good. It comes right back up, and now it's not entangled. It's somehow it's very,
because of the severe calcification.
very easy to entangle the pigtail with the valve.
Exactly. However, I think that go, please. Okay.
I think that's great. Perfect.
I think it's a good. So I think, may I have a test, Martina? Go.
Very high.
Okay. So, open.
The pigtail is about 3-4 millimeters above.
Yes, because it's because of the calcification, George.
Yeah, I see that, but I'm just saying for the audience to understand, the 4 millimeters above.
Open, open, open. Slowly. Okay.
Put the wire to put it down a little bit, right?
Well, they're going to do another injection probably very soon. You can inject also while deploying, huh?
In few seconds, George. Okay, test, Martina.
Yeah, you see we're high already.
No, I think.
Yeah, now we came a little bit lower. Okay, good.
Continue here.
Are you pacing? I think it might be good to pace.
Not yet, not yet, not yet. You'll see. You see
we'll pace for more stability because the wire the valve, the LV is hyperdynamic, so the Landequist transmits the heartbeats a bit more than otherwise.
So, 120, 120, please. 120.
Inject a little bit.
Now it's in the point of no return. Now we have to open up the valve and then evaluate.
Test.
Unfortunately, the pigtail was pulled up by the valve. Unbelievable.
The pigtail, it's very difficult to. So this time, continue 140, 160, please. No, continue.
Just uncover the valve at least a little bit, so there's some valve function. You can stay there now. At least there's valve function now. Patient is stable.
Very, very stable, you can see.
Now you can figure out a little bit the pigtail position and do a better angiogram. Okay, great.
Okay. So
at least now the valve is open. It's not released, can be recaptured again. It's a little bit on the low side, but...
like this. So I think it's in a deep position. So we'll try to reposition.
Yeah. I would say be a little bit more liberal with the injection because this, and pace from early on. Maybe not 180, but at least 120.
Okay, test please.
Epsilon.
Fine.
Good.
Test. Go.
Very good. Keep it there. Pace faster and release. Open up a little bit to the functioning valve. Very good. Go open. I think we accept the OE comes come back a little bit.
Top. 120.
I came down again.
Voudris.
Okay. Test,
you may want to push the wire a little bit so you can keep the valve in place.
Pull the wire.
120.
Keep the valve in place.
Higher. Yep. Yeah. That's right. Okay. Push wire a little bit, the pace, fast pace, in order to do that.
At the end, George.
And inject at the same time. I think I'll do liberal with injections. Just keep injecting. Don't worry about the dye.
Okay.
This is a very tricky situation because these maneuvers from the subclavian axis and the choroid axis are very difficult because, you know, all the equipment is long. One thing I will worry in this case is the dye. Don't worry about the dye.
Stay there, please. Stay there, please.
No beautiful. You see now, you thought it's high, but somehow it opened that beautifully.
Excellent.
Very good. Keep there.
Forward pressure on the lung request. Forward pressure on the lung request, so it doesn't die.
Maybe it's shallow.
Right. I think we got it very well.
Yellow, please.
Okay. Let's make it. Put a little forward pressure. Yeah. And let's take a pressure. Take a picture. At least now the valve is open. It's a 3rd degree. I think it's much better than before. Before it was 2 diamonds. Now we're in like maybe 3/4 of 1 diamond. 3/4 of 1 diamond. It's you can go of course to the other view as well. Let's align them though. They're not exactly aligned. The 3 dots. So.
Once again.
No, he didn't like it. He got to go a little bit high. He wants to go a little bit high. But push the wire at least so they can move you up. Yeah.
There. Stay there. Stay there. Okay, γράφουμε παρακαλώ. Okay.
Yeah, you can see the difficulty of the difficulty is that the equipment lengths are not optimized for a subclavian carotid insertion. So
to replace the contrast media.
Yeah. The patient is very stable, and
it's stable, but by the end, George, it's not so easy to stay. Δώσε βηματοδότη. 120. Δώσε. Εντάξει, μια χαρά είναι. Please, stay there. Το μπαλόνι κάνει τι σημαίνει. Okay. Λίγο πίσω, γιατί δεν θα ξεσπάσω λίγο τον μπαλόνι του βηματοδότη. No problem. That's the super.
So, George, I think it's one of the issues when you deal with transaxillary access or carotid. It's sometimes you have it's not easy to have proper alignment of the valve as opposed to the annulus. So sometimes you need, as Kostas said, you need to push the wire a little bit. And then
you need to put the wire. I think, in all honesty, you need someone, regardless of a radiation exposure, you need a person to handle the equipment right at what the sheath is. And sometimes, because of radiation exposure, many people handle the equipment from a little bit further out. But it's just the torques and all the maneuvers don't transmit very well. So you got to have someone at the sheath, at exactly where the sheath is, close to the camera, unfortunately. So that's a trade-off of this and the difficulty of this position.
Maybe sometimes you need to start opening the valve a little bit higher, and then you will anticipate those markers.
We saw that happen before. We were malaligned and a little higher up, and then once we opened it, it dived, and then it kept diving. So although we started high, ended up, I would say, at 3/4 of a diamond. Optimally, you want it at like 1/4 of a diamond in this case. I'm not sure if we're going to be able to achieve that, but we'll try.
Η πίεση λίγο. Τι?
Meanwhile, we've been in this position quite a bit. The pressure is going a little low, so we have to, I think, make the attempt again, because now the valve itself is obstructing a little bit the annulus.
It's alive.
Okay, a little bit of a problem with the pacemaker at the same time. Is this a EP pacemaker? It's a balloon guided pacemaker. Is it a balloon tip pacemaker? Doesn't seem so.
It is a balloon.
Balloon, okay. We don't see it inflated.
But you know, the anatomy is really funny.
Yeah, we don't see it inflated, so I don't know, maybe deflated or maybe a balloon burst or something, we'll see.
Yeah.
Yeah.
All right, any comments from the panelists that are online? If you want, we can just speak and share your comments about this case thus far. Is a right subclavian access TAVI. Dr. Dvir, Katsimagklis, Leontiadis, Spilias, Dvir, and Georgiou. Any comments? You please volunteer your comments. Just go right ahead and talk.
Yeah. Okay, so that's it. Σταθερό. Δώσε και έτσι όπως είσαι.
Yep.
Το καρδιογράφημα να βλέπω. Έλα, δώστε τη βηματοδότηση. 120.
Δεν το έχει συνδέσει.
So I think they changed the approach now. Now they're using the crocodiles And they were pacing through the wire.
Doctor, I see Dr. Finkelstein wanted to make a comment. Go right ahead, Eric. We can hear you. Don't worry about seeing or not seeing and all that. Just make your comments.
Hi, George. Thank you. I usually prefer to make comments not during the implantation. I think that a team that took over to do a live case are pretty experienced without my help. But just in general, before they are starting the money time, I think the pacing in this case is extremely important. So before starting the implantation, I'll make sure that the pacing is good. Second, I'll pace in many cases on 140 because 120 many times does not catch the VPB, and it might be pretty dangerous. Third, as you already mentioned, I'll use the wire as a tool much more than in other cases, because since this is a right subclavian, the angle in which the valve is approaching the annulus is very, very uncomfort. So the usage of the guide wire is extremely important in this case. And otherwise, just let them work. I think they're doing a wonderful job.
No, but yeah, the comment doesn't have to do about the tips and tricks of this case. More of a general case, I would say. I mean, I wonder if the Confida or the Safari might be more permissive for the angle. Sometimes these stiff wires helps you get in, but then biases you a little bit more against the one wall, and maybe interferes with the eccentricity. Plus, somehow I felt that every case with a Landequist, the heartbeat is felt more from the wire to the valve versus with the other wires, because it's stiffer. I think that's understandable. You feel the apex push more so than, and in this system that is not a very long, the wire is very short from guide to LV apex, probably you feel it a little bit more. Okay, anyhow, a new valve is going in now.
I completely agree. I completely agree. Yeah, right.
Go.
So we're going in with a brand new valve because the previous valve was opened and recaptured more than the 3 times. That is the 4th time. That a 4th is final, but we're over that. So now we're with a brand new valve system. Let's see how that goes. The pacemaker is okay. The pigtail is in a better position, and we have 3 more attempts to go. Let's see. Again, I would pace, be more liberal with the pacing, and we're more liberal with the dye because we need to somehow be able to see better and immobilize better the system.
So, Georgiou, we replaced the valve because we tried 3 times. So we okay, top. That's good.
And now the pigtail is the better position.
Yeah, also. Yeah, everything somehow works better now. The pigtail went into the position that can help us. We can magnify if you don't mind. That will be a little bit of help. Yeah. Good. Perfect.
Test. Okay.
Perfect. If you stay there, that will be perfect. Let's see. And it seems like it stayed there.
120. Okay.
Okay, it's diving, so go faster pace and faster release. Maybe push a little the wire because it has a tendency again between 20% and 80%. It was diving in the previous cases.
It's already done, George.
So now it's better. Yeah, great. Let's stop there. I think we got it nicely this time. And very good. The valve now is functional. The patient is hemodynamically very stable. And we're good.
Yes.
We're half a diamond in one and maybe 3/4 are the other, but very acceptable. Eric?
Okay, now the patient is stable, okay? Right? So no hurry. Now listen to me. Now go to 3 different angles. One is three cusp. The second one is the cusp overlap. And the third one should be left LAO caudal.
Don't forget that this lady has a severe kyphosis. So this is a main problem, okay?
Okay, but she's stable. You have your time. Now go to the three views, and you will be much more confident of your depth of implantation.
I think it's good the pacing can continue at maybe at 100 unless you're ready to release.
Yeah.
Amen.
You're ready to pace at 140 now.
You can go to 100. Okay. It's okay.
Go. I think that this position is acceptable.
Yeah, this is what? What's the angle, this?
Yes, okay, this is a right caudal. Sorry, left caudal.
Left caudal.
Yes.
Okay.
So, please. 140. Είσαι live.
I think once you release it, the valve will be less deep in the on the left cusp, because right now you're biased because of the Landequist. Make sure it doesn't fly out.
60. Okay.
Yeah, and it did exactly that. You see the valve rotated counterclockwise as soon as you released it, and it's in a more favorable position than before. But I think one of the anchors is still attached. I don't know, somehow in this subclavian accesses, the anchors are attached more frequently than otherwise. Just to make sure we see that. Is it attached? No, I think it's detached. I can't tell from here very clearly, but.
And sometimes for the final, if you pull the wire into the nose cone, it may help a little bit, you know, keep it more aligned.
Yeah. Yeah, but now she's pulling the wire back. It's okay. Now it's somehow worked out.
The diastolic pressure is 55.
Oh, that's very good. Because the systolic doesn't seem to be very high either. All right, so let's see now. We put a pigtail in and figure out the situation.
Σύρμα παρακαλώ.
It's a very demanding and challenging case, and one can say, okay, great, from the innominate artery, we're straight down into the aorta. I get it. At the same time, the equipment is not dedicated, and the length of this equipment is just unrealistically, I think, difficult to complete the case 1 to 3 as you think. So you saw the difficulties and the great result at the same time, but you have to have a lot of tips and tricks to configure the situation favorably. It's just by no means a simple thing just because you're right there. All right. Are you removing the valve and replacing the valve system and replacing with a with a pigtail? Yes. Very good. That's the next step.
With the guide wire, we remove the pigtail. Don't forget it's a small annulus, huh? Okay, let's have an orthography. Όπως είσαι, go, αορτό. Πάμε. Κάσου και στην πίεση θα κάνουμε και στην ανάμιση, στην ογδόη.
All right. So wait now to see the hemodynamic result.
Excellent. Let's go.
And
0, and the position is fine.
Yeah, the AR is very good. I mean, due to the fact that this valve is in a small size, although self-expandable, still the smaller size of those, 23, you're going to really see that the hemodynamics are good, particularly with the difficulties. Perhaps you need a post-dilation. I would place a pigtail in the LV.
Okay, but another option is to have an IVUS, but don't worry about it. Okay, because to put a pigtail, we need to put once again the sheath. That's fine, arthroscopy. Please. Is there any comment for the position?
No, position is very good. It's excellent, given all the difficulty and the bias towards the medial wall of the aorta. It's great. Any comments from the panel, please?
Any comment?
Any comment from Eric or Danny or Dr. Spilias and Georgiou? Leontiadis?
I think it's a very nice implantation. I think you can argue with it. And just when injecting, I'm taking the super stiff wire out because sometimes it is just distorting one of the leaflet of the implanted valve. And then you see AI, which does not really exist. Anyhow, you see that even though there is no AI, we'll see the gradient in a minute, the true gradient, and I think it's a beautiful implantation.
Yes, but I disagree with the use of a Safari guide wire. I think the lateral twist in this case is most suitable. Oops.
Well, you disagree with what?
Sorry?
I didn't understand the comment.
The comment is about the guide wire.
No, I said that I would take the guide wire out before injecting to see the AI.
For you during the implantation.
Ah, okay. You are talking about the implantation itself.
And a pigtail.
May I have a pigtail, please? In our experience, because we have a lot of cases with subclavian artery, mainly right subclavian artery, that it's very unusual. After the deployment of the valve, you see that the position is quite different. So if you have high implantation.
So the access, let me ask you, the access is managed now. The vascular surgeon has placed a conduit,
yes,
and then just wraps the conduit on the way out.
Exactly. That's the best way. Because we were working with this team many years, and we are familiar with this technique.
So I need to understand. What you said is that in right subclavian,
yes,
you prefer for positioning the Safari wire over the Landerquist.
I thought that I prefer to have the Landerquist instead of Safari for the subclavian artery.
Okay, so you said that you prefer the Landerquist.
Nice to hear you. You remember last time we have the discussion about the FX valve. You remember?
Right, of course.
And I promise you that this year I will implant a valve like this. And I'm very happy because you are in the panel, even from the country.
Yeah, I remember.
You remember?
Of course.
That's fine.
Yeah.
I'm sorry. That's for me. Thank you. Thank you. It's okay. So.
Τη δεύτερη πίεση θέλω.
Αυτό είναι το προηγούμενο.
Τέλος πάντων, αυτή είναι η πρώτη πίεση.
Pull back.
Όχι, είναι πίεση. Να δω λίγο. Εντάξει.
Okay, pull back. Pull back. Have a look. No gradient. Okay?
Beautiful.
Right, great. I think it was a terrific result. Congratulations to Dr. Voudris and the co-workers at the Onassis Heart Center. Very, very challenging case, as we heard.
Have a look, for the look on the position of the pigtail and the swan glands.
Very good. So I think we're going to let them complete the closure of the case per the vascular surgery team. Congratulations again. Let's move on.